Basics to complex cases. So Professor Tityal is the chief instructor. He'll be joining us shortly. May I invite all the co-instructors on stage, Dr. Ramamurthy, Dr. Mahipal Sachdev sir, Dr. Suven Bhattacharjee, Dr. Arup Chakravarti, Dr. Partha Biswas, Dr. Abhay Vasavada. We'll start with the first talk by Dr. Mahipal Sachdev sir, Phacoemulsification in hard cataract.
Good afternoon, everyone. I wish to thank Dr. Tityal for having me in the course. I'll be talking about phacoemulsification in hard cataract. Why is hard cataract a challenge, and as to why one needs to look at the things that are required to manage a hard cataract. It has been shown in several studies. This is one of the important studies, that is the Swedish capsule rupture study. This is the report that is there, which technically has looked at the reasons or the percentage of PCRs in various cases, and it has been shown that white and brunescent hard cataracts are associated with an increased risk of capsule complications. So therefore it is important that we don't end up in complications, that we need to know as to what it is. When you're looking at a hard cataract, there are several preoperative considerations that you have to look at, and often the hard cataract has been sitting in the eye for a long time. That's why it has become hard, and a lot of these patients nowadays are on tamsulosin. So this compounds the problem further, and therefore you need to look in the OPD at the pupillary dilatation. You have to look because these patients are aged and the cataract would require more energy for phacoemulsification. You have to do a specular to look at the corneal endothelium. Even if you don't have a specular, do a specular reflection on the slit lamp. Zonular integrity is important. Then you need to look at the grading and the morphology of the cataract, and also often these hard cataracts are associated with diabetes as also high myopia. So you need to do a posterior segment evaluation in this. Now, why is hard cataract a challenge? The hard cataract is a challenge because often they have bad corneas. There is a whiteness with a hard cataract, and you don't get a red reflex. There could be milky fluid, so therefore you have compromised visibility in cases of hard cataract. Second is that there could be associated fibrosis, so difficulty in doing a capsular access. So capsular changes and poor visibility can be overcome to a large extent by using trypan blue. The AC depth can be reduced because the lens has grown in thickness, so there is less space for surgical manipulation. There are often corticocapsular adhesions, so forceful hydrodissection, delineation or rotation of the lens could cause problems, and the main important bug is the leathery fibers which attach the lens at the back, which is the problem. So when you're looking at the nucleus, what is very important is that you should understand the nucleus anatomy, and if you look at the nuclear anatomy, the central portion of the nucleus is the thickest. So what is important in any cataract, more so in a hard cataract, is to break the central core or the backbone of the nucleus. The nucleotomy is your wish, 100 ways to skin a cat. So whether you do a trench, you do a split, or you do a chop, that is for you to decide. But what is important is that in a hard cataract, you should be approximately 85 to 90% thickness of the nucleus to be able to break the nucleus. Otherwise, you will not be able to split the nucleus which is there. So this is important. When you are doing a splitting or the crack of the nucleus, what is important is that a superficial crack, if you put on the top, the vector forces will go like this and you will not get a crack. So therefore what you have to do is that you have to do a trench which is deep enough, and you need to split it. You have to split it in this manner. Now the nuclear emulsification, the chopping techniques can be divide and conquer, stop and chop. You can do a primary chop, crater divide, circumferential disassembly, etc., etc. My preferred technique is always to do a primary chop. There can be differences in the primary chop that you do in a rock hard cataract. First you make a crater and then chop. You can sculpt and then chop. You can drill and chop. So this is the modifications which allow you. So let us see. This is once the sovereign machine came, we were able to work on higher pressures, higher fluidic these things. So this is going in deep. Important thing is you can see that we are looking at vacuums which are going up very high. It is the central portion that we have embedded. Once we have embedded the central portion, you can see that we are cracking. The important thing in the crack is that you have to go past the midline. So you can see here that we are going past the midline. I would prefer to rotate it and then again go. You don't need to, you can actually go behind, but what you have to break is the central, and you can see once the center is broken, you will be able to take out. Breaking the backbone of the cataract, as I have shown you, is what is very important. You can see again there is a hemisection. Again, go deep. See, look at the depth of it, and once you have seen the depth, you can see that you are actually breaking it and again taking it out into two pieces and then another piece. This is a pre-chopped black cataract. You can see with a femto, a good capsular excess has already happened. You can again see that we will do minimal hydrodissection, and just watch here that this is again a good femto procedure that has happened. Just watch the air bubbles that are going to come out from here, which is going to show you that this, can you see this? So this shows that the incision or the femto fragmentation has happened. And again, what is important, what I am trying to show is this disenclavation at the center. What is important is a rock solid hold. The tip of the phaco has to be not it has to be less beveled. That means that you can do a 0-degree tip or a 15-degree tips. That's what I use. Look at how black the cataract is, and we have been able to, because of the use of femto, reduce the phaco energy. But the important thing here that I wanted to tell was that you have to break the backbone of the nucleus. Now, intraoperative problems that are there, difficult situations during nuclear emulsification is if you have incomplete separation. If you do not separate the fragments completely, they will keep sticking, and that is the time you have PCRs, because it's just the thin back part of the nucleus which you are going to do. Other important thing is that there is no epinuclear cushion that is there for the protection of the posterior capsule. OCT can be a good guide, and you can see here this is a white cataract and a hard cataract. The OCT is showing you there is the swollen intumescent cataract which is there, and as you can see, you can easily see that there is this liquefaction which is going right up to the bottom. So this is going to be a milky fluid which is there, which is going to allow you, that's the capsule. You can look at the integrity of the capsule that you can. So intraoperatively, if you have a PCT, you need to detect it early and not fish for the nucleus. Management would depend on the procedure. If it is a hard cataract and you still have a bulk of the nucleus that is there, then you are in a deep problem. And anterior vitrectomy through the posterior route is something that would require. Post-op consideration, there is prolonged surgical time which leads to increased inflammation. AC inflammation can have CME, so you need to have intensive topical steroids. Cycloplegics are required. I would prefer to give a homide or a atropine, because a lot of cyclitis, if there is, then it causes inflammation and increases the risk also of CME, and the corneal edema tends to go back, go down in a later stage. So friends, this is the journey of a hard cataract that I have brought before you. Key points are that you have to look at everything pre-operatively, have a proper machine. Only good machines can give you good holds, and good holds can give you the breakage of the cataract in the center. Do not allow the spine to persist. If the spine persists, then there is going to be a problem. Use viscoelastic, BSS, BSS plus, chondroitin sulfate, etc., and post-operative management is required. Thank you very much for your kind attention. Thank you.